Hiromichi Aito from Tokyo, Japan, Dr. Abul Hassan Kasmi from Nine Wells Hospital, Dundee, Zishan Razak from Cork University Hospital, Professor Fawzia Rana from Jacksonville, Florida, Dr. Mubashir Chima from Nottingham, and many more would also participate as keynote speakers. Come and join us for this virtual symposium. Welcome to Shalamar Medical and Dental College for 5th Virtual International Conference and 5th Virtual International SMDC Conference under the leadership of worthy Principal Professor Zahid Bashir and Professor Khwaja Muhammad Azim.
Bismillahirrahmanirrahim. I'd like to welcome you all to the 5th Surgical Symposium being held as part of the 5th International Conference of Shalamar Medical and Dental College. Professor Khwaja Azim and his team have chalked out a very comprehensive program for the surgical symposium, and I see the list of speakers includes some of the best names in their specialties, in their areas of expertise, not only from Pakistan but from all over the world. The surgery department at Shalamar Medical Dental College has always been in the forefront in arranging academic activities, and their contributions during each one of the previously held conferences has been substantial. And I'm sure that this symposium being held this year will not only be as good as the previous symposia, but will take it to a next level. The array of speakers are wonderful people. Some of them are my teachers, some of them have been my mentors, and I'm sure every participant, every person who attends these symposia will be enlightened and will go out enriched with technical expertise and with knowledge and skills. We wish all of them good luck, and I'm sure that all of you will learn from this. This symposia covers almost every aspect of the surgical specialty, from bariatric surgery to cosmetic surgery to endocrine and breast surgery and to oncology. So it's a very comprehensive symposium, and anybody working or anybody learning in the field of surgery, I'm sure will enjoy this, and this will be a great learning experience. Good luck to all of you, and I hope and pray that you enjoy it. I'd like to thank you all for coming in and attending this symposium, which I'm sure will be helpful for all of you. Thank you.
My dear colleagues, Assalamu alaikum. It is a great pleasure for me among the galaxy of surgeons. I am Professor Khwaja Muhammad Azim, working as a chairman, Department of Surgery, and I am President of Pakistan Endocrine and Thyroid Association. Shalamar Medical and Dental College, Lahore is organizing the 5th Virtual International Conference from 1 to 6 February 2021. Department of Surgery would be conducting a section of it under the title of Shalamar Surgical Symposium to cover the surgical discipline and to cater the surgical community. Shalamar Surgical Symposium provides an exclusive platform for new researchers, scholars, physicians, surgeons, students, and educators to present and discuss the most recent innovations, trends, and concerns, practical challenges encountered, and the solution adopted in the concerned field. The session will include keynote speakers, session speakers, poster presenters who will be presenting their advanced research on some of the important topics in their respective fields. Organized by the Shalamar Medical and Dental College Department of Surgery from 1st to 6th February 2021, In Lahore, the conference will bring together national and international experts, providing them a platform to exchange their knowledge and learn for each other. This session has many national and international speakers, and hopefully it would be benefit all of the attendees. Thank you very much.
Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alameen Ar-Rahman We are going to start our first virtual session of the 5th International Scientific Conference at Shalamar Hospital under the chairmanship of Professor Khaja Azim. And it's a great honor for me. And we have got very well-known and distinguished speakers with us, and we will elaborate different pros and cons of bariatric surgery. We don't want to waste our time. I'll just briefly review. It's our practice that we have been organizing this conference since last 5 years successfully. And there were live surgeries in those conferences, and all international and national speakers and surgeons were there. So we were pleased that this time, because of the COVID situation in the country, we were unable to have live sessions, and that's why we have a virtual conference. I just want to elaborate the rules of the sessions. Just briefly, moderator would initiate the session with permission of the chair and co-chair. Panel discussion will have a question and answer session would be at the end of the talk. Audience can post their question in the Zoom chat window or can email us at the email you can see on our screen. And the speakers, please stick to your time limit, that is 15 minutes for the invitee talk and 10 minutes for the research paper talk. And all the speakers and audience should mute when not presenting. The people not presenting should also not share their videos so that bandwidth remains on the quality of live cast remains optimal. So this is message of the chairman, Professor Mumtaz Mehr, as a chief of surgery at South City Hospital, Lahore. He introduced bariatric surgery almost a decade back in Karachi in May 2008, and since then he has done wonderful achievements in bariatric surgery, and we are pleased to have him on board with us. And Professor Farooq Afzal, he's a well-known person, also president of the Society of Surgeons of Pakistan Lahore chapter, and he is General Secretary for the Pakistan Society of Bariatric and Metabolic Surgery. He will deliver a short talk on the novel modern techniques of bariatric surgery. And he has got great experience, almost 22 years. He's a great teacher and well-known personality all over the world. And Alhamdulillah, I am working as a professor in Shalamar Hospital, and since then we have made a center that has got a great repute, and up till now we have got the highest number of cases in Pakistan in our center. And Alhamdulillah, we have got an honor of arranging first international conference at the platform of PSMDS 2 years back. So inshallah you will be delighted of regarding the talk of our legends in this bariatric field. Everybody know this great man. He's my brother, Dr. Tahir Younis. He has got great experience, almost 15 years, and he worked in US, and he was chairman in Jeddah, and now he is working as a consultant in Evercare Hospital. He's a great clinician, and he will just deliver his talk. He's the first speaker. Dr. Ghulam Sadiq, he's a general surgeon and bariatric surgeon. He's chief of surgery in Shifa International, Islamabad. He is a great friend of mine. He has got a great experience of bariatric surgery, almost more than 10 years. He is just going to talk about gastric bypass. Dr. Atif Shami. And Dr. Atif Shami is a friend of mine. He has got great achievement, excellent surgeon, and he has learned technique from Dr. Rutledge of mini gastric bypass, and he will tell about how to do mini gastric bypass, a single procedure in super obese patients. So I'm now inviting Dr. Tahir Younis. He will just present his talk, and Dr. Tahir Younis.
Assalamu alaikum. Can you hear me?
Yes, Dr. Tahir Younis, we can hear you.
Okay, I'm trying to start my video, but it keeps saying that the host has blocked it. Can you please open the video?
Open the video. Just 1 second. Okay now. Is it opening now?
Yeah, it's open now. Okay, 1 second. Let me just, my computer is asking me for a password. Available for view. Can you see my screen?
Okay, yes, we can see.
Okay, all right. All right, Bismillah ar-Rahman ar-Rahim, wa salatu wa salamu ala Rasulil Kareem. Thank you very much, Dr. Muaz, for the invitation and for the opportunity to talk. And thank you all the organizers and the conveners of this excellent event. And thank you very much for the audience to participate as well. The discussion of today's talk is overview of obesity and the treatment, the different treatment options. We're going to look at a little bit about the concept of energy balance and the regulatory mechanisms that are controlling both energy in and energy out, and the treatment options that are based on this concept. So we'll just start off with this short 2-minute video about an update about the statistics that are currently for obesity.
Obesity. Obesity is a condition that is associated with having an excess of body fat. Obesity is classified as having a body mass index of 30 or greater. 3 decades ago, the obesity rate for adults was 15%. Today, the rate has more than doubled to 35%. At the same time, calories consumed by adults have gone from 1,996 to 2,234 a day. Obesity. Obesity is a condition that is associated. Today, the rate has more than doubled to 35%. At the same time, calories consumed by adults have gone from 1,996 to 2,234 a day. Obesity-related conditions include heart disease, stroke, type 2 diabetes, and certain types of cancer. These are some of the leading causes of preventable death. The estimated annual healthcare costs of obesity-related illness are $190.2 billion, or nearly 21% of annual medical spending in the United States. Obesity-related job absenteeism costs $4.3 billion annually, and obese people spend 42% more on healthcare costs than healthy weight people. African Americans have the highest age-adjusted rates of obesity at 47.8%, followed by Hispanics at 42.5%, Caucasians with 32.6%, and Asians at 10.8%. There's no significant relationship between obesity and education among men. Among women, however, there is a trend. Those with college degrees are less likely to be obese compared with less educated women. Higher income women are less likely to be obese than low-income women. The United States is the 8th fattest country in the world, with 31.8% of the population being overweight. The top 3 fattest countries are Egypt with 33.6%, Saudi Arabia with 35.2%, and Kuwait with 42.8%. The fattest states in the United States are Delaware with 34.3% of its population being obese, West Virginia with 34.4%, and Mississippi with 35.4%. While obesity is a major health and economic issue, recent studies have shown that childhood obesity among 2 to 5-year-olds has gone down from 14% in 2004 to 8.4% in 2012. Thanks for watching, and if you'd like to watch more, make sure to subscribe.
Okay, so now it's quite obvious that obesity is a growing problem across the world, and in Pakistan is no different. We have a steadily, progressively increasing prevalence of obesity. And so now I think it's about 20% of our population, and it's around that number. But it's unfortunately we don't have accurate measures, but it's getting high. And we are amongst the top 10 countries in the world with absolute numbers of obesity. So it is a big problem. And obesity has a lot of impact. I mean, when you're walking around in the markets and, when you look around in your workplaces, it's quite easily that you'll identify that it is a problem. And many people are actually struggling with it. I myself am continuously conscious about whether I'm gaining weight or not. I mean, it's a constant battle. So we have to understand how does it work? I mean, what is causing obesity in our societies? I mean, it's good that we're doing surgeries to help everybody, but I mean, you can't just operate on everyone. And we need to know what's happening, what's the cause, what's driving this pandemic. So the impact of obesity right now is multiple. One, it's psychological. I mean, it causes depression, social withdrawal, and a lot of other problems with children who are going to school. It reduces their confidence levels, their inability to participate in activities with the rest of their groups. It leads them to start delving into an internet world. They don't have real friends. They only have net friends because net friends can't talk about their weight. Then there's a mechanical impact, where the weight itself has an impact on many of the body systems, starting from the musculoskeletal system, then going to the airways and sleep apnea. It can cause GERD, reflux disease, urinary stress incontinence, and a host of other issues just related to the mechanical impact. Then there's this metabolic effect. So the understanding that fat is of 2 types. There's a subcutaneous fat, then there's this visceral fat. And visceral fat accumulates within the cells of different organs and causes an inflammatory state. And that inflammatory state then leads to the development of different diseases. For instance, we get an ultrasound report saying it's fatty liver. And we say, okay, it's fatty liver disease, just fatty liver. But fatty liver will be the major cause of liver failure, and it will outnumber the hepatitis C. It'll become the #1 cause of liver failure in the next 10 to 15 years. That's the prediction. And we're already seeing that. Many patients that we start operating on, we see that there's already got compensated cirrhosis. Fatty liver is identified, but you can't identify fatty lung disease until you do an MRI. You don't identify fatty pancreas until you do an MRI. And not everybody gets an MRI. But if everybody gets an ultrasound and we know that there's fatty liver disease, there's a good likelihood that they have fatty lung disease and fatty pancreas disease. And so when they have fatty lungs, they get when they move around. When they get fatty pancreas, then they develop insulin resistance and type 2 diabetes. They most likely also have fat around their heart that can contribute to the development of heart disease, coronary artery disease, and hypertension. So all of this is part of the metabolic syndrome that develops as a result of the accumulation of visceral fat. So to understand the reasons behind this, we have to first of all understand that there's an energy balance, that our body is storing energy in the form of white and brown adipose tissue. And there's energy in and there's energy out. Now, white adipose tissue is static, and brown adipose tissue is basically brown because of the accumulation of mitochondria. So the more mitochondria that exist within the lipocyte, the more the breakdown of the fat that is within that lipocyte by lipoprotein lipase. So lipoprotein lipase is the enzyme that is breaking down fat in the fat cells as a result of mitochondrial activity. And so they're driving the fat into development of releasing energy, which can be used as thermal energy as well. And so Brown adipose tissue is a small amount in our body. Mostly it's white adipose tissue, and brown adipose tissue is around the kidneys, it's between the scapula, and in some parts of the chest. But studies have shown that when you are exposed to 17 degrees Celsius temperature for 2 hours a day over 2 weeks, then there is browning of white fat. So you can actually stimulate white fat to start getting brown by exposing to cooler temperatures. And that is also considered one of the reasons why it is possible that we are developing this obesity problem, because we're also now having less exposure to cold temperatures. We're living in very insulated environments. We have insulated houses, we have warmed up cars, we are wearing layers. We're not as exposed to cold as we used to be. Energy in is, of course, affected by multiple things, amongst which is portion sizes, which has gradually increased over the years. We've identified how the amount of calories globally per person has increased. Food choices have dramatically increased over the years. And every day, the food industry is trying to bring up a new option to eat. We are constantly in search of new flavors and tastes that would satisfy our palate. And then there's this issue of eating stimuli. We're constantly bombarded with different marketing advertisements that are stimulating us to eat. I mean, you open up Food Panda and the pictures that they take are such excellent photographs. I mean, you don't see them otherwise. In reality, the food doesn't come like it is shown in the pictures, but it stimulates our palate. Then there's social dining. We many times have to eat even if we don't want to eat, because we have to eat, because we're in a group that is expecting us to eat. And then when we are under stress or we're looking for comfort, many times food is the best friend. It doesn't talk back to you. It's constantly there. It's available. It listens to you when you're in trouble. It helps you. It releases serotonin in your brain and helps relax. And so that's how even many of the marketing things are done with chocolates, with ice creams. They tell you how to relax with chocolate and ice creams, which drives a lot of calories into the body. Now, energy out is, of course, most of our energy out goes towards basal activities. So 80 to 90% of our energy that we consume is used to just the daily amount of energy that a body uses for basal work, basic metabolic rate and resting metabolism. There is some amount of energy that is utilized towards physical exertion, but on the average, it's usually around 8 to 10%. It's not much than that, even possibly lesser in some ladies who are just staying at home. And then the thermal heat used to be higher, but now it's down to 2 to 5%. So we've developed over the years very efficient body systems that are constantly preserving energy in our body and not letting it be lost, defending us from an environment of famine that may come around. So the question is then, does lifestyle actually matter? Yes, it does matter. So when there's this famous study that was done by the Diabetes Prevention Program called the Reduction of Incidence of Type 2 Diabetes with Lifestyle Intervention, or metformin, to see which one actually works better. Is it lifestyle that works better or metformin that works better in reducing weight and controlling metabolism and controlling diabetes? And so there was a group that was given lifestyle intervention that they were asked to exercise 150 minutes a week, which is not too much. It's about 20 to 30 minutes a day. And they were counseled to change their eating habits and try to lose up to 7% of their body weight. There was a group that was told just to take metformin. And there was a group that was given medications, but it was just placebo. So when they followed these groups over the course of the next 4 years, there was a 58% reduction in the development of diabetes in just the lifestyle intervention compared to placebo, and a 31% in the metformin compared to the placebo. And so it was very obvious that there was a significant difference achieved just by modifying lifestyle. And so modifying lifestyle can play a big role in controlling our metabolism and controlling our disease. So it really does make a difference. And it's just about counseling our patient, trying to make them aware of the hazard of obesity and the benefits of lifestyle interventions. So it requires a little bit of counseling there. There was another study, which is called the Prevention of Type 2 Diabetes with Lifestyle. And it was done amongst patients with a BMI of 31. And both of these studies had massive population sizes. I mean, their samples were in the thousands. So the previous one was 3,000, and this one was around that area as well. And so the patients were, the intervention group actually achieved a 4 kilogram average weight loss. So every patient had an average of about 4 kilograms of weight loss. And just by losing 4 kilograms of body weight, they were able to reduce the incidence of type 2 diabetes compared to the control group from 23% to 11%. So it means that somebody who has a BMI of 31 in the course of 5 to 6 years has a 23% chance of developing diabetes unless they adopt some sort of lifestyle interventions to control that. And just by adopting lifestyle measures, they're able to half that amount or even more. So they've got about a 55% reduction in the chances of developing diabetes in the next 5 to 6 years. And so a lot of us surgeons are in that range of BMI 30, 31. And this is something we all need to be sort of an eye-opener to each one of us. So what are the lifestyle modifications that are required? Well, we always talk about having a psychologist on our multidisciplinary team. So what does that psychologist expect to do? So we're trying to counsel people on aims of healthy living. What are the needs for them to do in their changes in the life that they need to bring to have a healthy life? So it's controlling their portions, controlling their choices, treating their eating disorders, and then counseling them on physical activity. Tell them that they can get cardiovascular benefits just by a 23-minute light to moderate intensity exercise. So it's about a walk of 23 minutes a day. It will give you cardiovascular benefits and reduce the risks of hypertension and coronary artery disease. If you go to 45 minutes, you're reducing the risks of gaining weight, and you're able to maintain any weight loss that you achieve through diets. And if you're able to go to 60 to 90 minutes a day, you will achieve weight loss by physical activity. So if people say, well, I've started a physical activity to lose weight and I haven't lost weight, it's because they haven't reached the amount of exercise that they need to actually get meaningful weight loss. So I tell my patients, it's like turning on the hot water when you're taking a shower. The more you increase the hot water, the more the water gets warm. It's the same thing about exercise. So you'll get this, and then you get that. And then if you really want to get a nice warm bath, you need to go to 60 to 90 minutes to get some weight loss. So how does the feedback mechanisms work that are controlling our body weight? Because our body weight is controlled by our brain. And I tell everybody that, look, it is our brain that is determining the amount of fat that is stored in our body. And there is a center in our brain, in the hypothalamus, that is controlling your body temperature, that's controlling your blood pressure, and is controlling your body weight. And so if they show a little bit of pessimism when I say that your brain is controlling your weight, so I give them this example. I said, well, change your body temperature for me. If you think you have control over your temperature, then change it for me. If you have control over your blood pressure, then try to change it. They can't, and they know it. And so I tell them that this is how it is not always in your hands to control your weight, because your weight is being controlled by a set point within the brain, and that is being affected by the lifestyles that you're living. So the lifestyle and the set point, they work together. And so the hypothalamus is controlling that energy balance as well. And the hypothalamus in particular, it's the paraventricular nucleus, that the red neuron that's on the top of the screen, which is in turn being fed by the purple, a gout-related peptide, and the green, which is the pro-opiomelanocortin nucleus. So on the bottom of your screen, you have your GI tract, you have your fat tissues, and you have your pancreas. So on a day-to-day balance, I mean, is the short-term balance is maintained by the GI tract. So the GI tract sends hormones, which are gastrointestinal hormones, that are affecting the paraventricular nucleus. And so they're controlling the food intake and energy expenditure. But in the long term, you have your insulin from your pancreas and leptin from your fat tissues that are also driving this feedback mechanism. And it is a disturbance within these feedback mechanisms that can lead the body to having more food intake and lesser expenditure and get diabetes, versus weight loss, which is less food intake and more energy expenditure. And that is where pharmacotherapy is then utilized to help control that feedback mechanism that is controlling our body weight. And so when we with the advancing research in the appetite pathway and the weight balance and energy balance pathway, we are identifying different receptors that we can start working on to help control our body weight. So the different drugs that have started off, the first one that became available was Orlistat, which was basically suppressing the lipase that is secreted by the pancreas, and it was not allowing the fat to be absorbed, and so you get a fatty stool. And so it led to a lot of diarrhea and a lot of abdominal bloating syndromes, and the weight loss wasn't actually that significant, maybe 1 to 2% total body weight. Then came around phentermine and topiramate. Phentermine topiramate combination was quite effective. Phentermine was actually increasing norepinephrine levels, and topiramate was affecting the GABA pathway, which was in turn affecting the dopaminergic pathway. And so as a result, it was suppressing hunger and cravings and helping in increased metabolism of the body because of increased norepinephrine. But it would also lead to a little bit of tachycardia and hypertension because of the increased level of norepinephrine in the blood. And it would also worsen anxiety. So if somebody had anxiety, that would get worse. On the other hand, topiramate was good for controlling migraines attacks. So if somebody has migraines, it might be one of the medications you want to consider. The other medication that became available was also called a combination of naltrexone and bupropion. And naltrexone is basically an opioid antagonist, and bupropion is a reuptake inhibitor that was stimulating the pro-opiomelanocortin nucleus. And a combination of both of these also helped reduce hunger, reduced cravings, and so was able to reduce the amount of food intake. If somebody had a smoking issue, it was good for smokers because bupropion is used for helping smokers stop smoking habits. Both of these medications on the average give about 2 to 3% total body weight loss. In best case scenarios, up to 5%, but not more than that. So if somebody was 100 kilograms and they started taking these medications, they would on the average in the course of 1 to 3 years lose 3 to 5 kilograms with maintained weight loss. So that is how we actually gauge our results. We don't look at short-term results at 1 month or 6 months. We look at least 3-year results because that is what makes a difference. There are multiple medications and different kinds of techniques that you can get short-term weight loss at, but it's not maintained. That's the issue. Another medication that came around was lorcaserin. Lorcaserin was a serotonin stimulator. The problem was that over the course of, it was approved in 2012 and then withdrawn in 2018 because of the increased incidence of cancer in patients who are using lorcaserin. So now it's off market because of the identification of cancer. Now comes this new group of drugs. Some of you may have heard and others may still not have heard of it. It's called GLP1 analogues. And I think it's important as bariatric surgeons who are treating obesity to be aware of GLP1 analogues because it is now going to be the new frontier in weight loss. And it is going to develop quite rapidly over the course of next year. So you're going to be seeing more and more of GLP1 analogues coming into play with endocrinologists. So liraglutide is the current medication that is actually approved as a GLP1 analog for weight loss. It actually achieves about 8% of weight loss, more than any of the other medications that we've talked about. So it's actually very effective in losing 8%. So if somebody has a weight of 100 kilograms, they start liraglutide over the course of 1 year, they can lose 8 kilograms and maintain it. If they add lifestyle modifications, that's another 5% there. And so in effectiveness, they can lose somewhere between 12 to 13% of their total body weight just by combining lifestyle modifications with a GLP-1 analog. Now, liraglutide does have some issues. It is an injection that is used like a pen. So it's like a pen-like injection that people use like for insulin. And it has to be given every day. So if somebody has a needle phobia, that is an issue. But it is a very small needle though. the cost of the medication over the course of 1 month is about 23,000 rupees. And in the course of a year is somewhere between 250 to 275,000 rupees. We start these medications at a BMI above 30. So it's not indicated for less than 30, any of these medications. So less than 30 BMI medications are not indicated. Pharmacotherapy is not indicated. And the goal is to achieve a 5% total body weight loss at 3 months. If somebody doesn't achieve that, then we either up the dose or we increase the number of medications that we're offering. And we always have to combine these with lifestyle modifications. Now, let's talk a little bit more about GLP-1 analogs, because it's going to be the new paradigm in obesity treatment in the future. It is a combination of two things. It's a neuropeptide. These are peptides that affect the neurological system. So that's why they're called neuropeptides. And it's also an incretin because it affects the metabolism of glucose. So GLP-1 analogs, GLP-1 are actually hormones that are secreted by our GI tract. And liraglutide is an analog. So it works on the same receptors as GLP-1, which is secreted by an intestine. Now, if you look at it, it actually increases memory in the brain. It's a neuroprotective effect. It has a positive effect on the heart. It increases myocardial contractility and improves the health of the heart, actually. It's quite beneficial for multiple parts of our body. Our pancreas gets better with it. Our liver gets better with it. Our fat cells start, the lipoprotein lipase is stimulated by GLP-1 and it starts breaking down fat. Our kidneys start removing excess water. Our endothelium is improved. Endothelium starts getting vasodilated and improved blood circulation to different parts of our body. And our muscle health actually improves. So there are a number of benefits from GLP-1 analogs. The current analogs that are available in the market are exenatide, liraglutide, dulaglutide, and it's now semaglutide, which is quite recent. Dulaglutide is probably something that you've probably heard. People use it by the name Trulicity. Exenatide is not that famous. So liraglutide is by the name Victoza. So Victoza and Trulicity are quite commonly used by our endocrinologists over here. And semaglutide is a new medication which you all need to know about because it has a very profound effect on weight loss. It's up to 13 to 15% of total body weight loss. So that is getting quite close to our surgical benefits as well. So semaglutide is now also recently been available as an oral medication. However, semaglutide is currently not been used in non-diabetic patients. So it's only indicated right now for the treatment of diabetes, whereas liraglutide can be used in non-diabetic patients as weight loss medication. And the reason is it does not cause hypoglycemia. So once the blood sugar comes down to 100, the effect on hypoglycemic effect of liraglutide finishes, but its effect on the GI tract continues. And what is that effect on the GI tract? Well, it affects in multiple parts of the GI tract and the satiety pathway. It increases appetite, reduces appetite, increases satiety by working through the same pathway that I briefly mentioned earlier. But it also reduces gastric emptying. And so gastric emptying has been identified as one of the important effects of both pharmacotherapy and bariatric surgery that promotes weight loss. And so it's something important that we all need to know about, how gastric emptying is being affected by these medications. And so once you start off GLP-1 analogs, in the beginning, the earlier effect at the lower dose is to improve the glucose metabolism in our body. And so it benefits the diabetic patients. And as you increase the dose, it starts affecting gastric emptying, then affects appetite, reduces intake, helps in weight loss. And then as you increase the dose further, it starts causing nausea, diarrhea, abdominal pain. So when you're using these medications, you sort of have to gauge, where do I take my patient up to? When they start getting nausea, vomiting, you sort of back off. And so this is how these medications work. And when you look at the physiology of bariatric surgery as well, it's interesting how bariatric surgery works in multiple areas, increasing the amount of energy expenditure. But interesting, if you look at the inner circle on this picture on the right side, where it says vagal manipulation, bile acids, gut microbiota, gut hormones. So these four are very much directly related to our GI tract motility and gastric emptying. And all of them actually then can also reduce hunger and increase our satiety. And so it is possible that some people have a more profound effect of these core changes than others. And so those patients get a lot of nausea after their bariatric surgery, and some don't actually get any nausea. It's very interesting. And so when you look at this picture, it's a crazy picture, but I like this picture because of two things. On the right side, you see the syringe with the GLP1 analog being instituted, and it's going towards the hypothalamus and affecting the arcuate nucleus and the paraventricular nucleus there. And on the middle of the screen, in the bottom of the screen, you see it affecting the pancreas. And then on the left side, you see how the bile acids, nutrients, and other things are affected through the L cells of our GI tract. And that's where bariatric surgery is also affecting GLP1 stimulation, which is then affecting our brainstem and our hypothalamus. So in conclusion, when we're talking about an overview of treatment of obesity, we have to understand that lifestyle modification forms the base of our pyramid, of our treatment pyramid. Where we start off, everybody who starts when we start getting into range of 25 to 30 BMI have to start looking at dietary modifications and physical activities, and the more the better. But once you start crossing that BMI 30, then we have to counsel the patients to potentially start considering pharmacotherapy. And so with lifestyle, you're able to achieve a 5% total body weight loss. With pharmacotherapy, depending on the medications and the dosages in your response, there is a 3 to 8% currently. And with the addition of semaglutide in the future, it's going to go up to 13%. And then when you counsel them for surgery, for total body weight loss, it is on the average 26 to 30% with a sleeve and 29 to 34% with any bypass you're talking about right now. So, except for the BPD, other than the BPD. But then obesity is a lifelong disease. And at 5 years, there is a possibility of weight regain with a sleeve about 20%, with a bypass about 8 to 10%. And that is where we go back to addressing lifestyle again. And then we may have to even consider pharmacotherapy to help our patients at that point. Thank you very much.
I need to have.
Thank you, Dr. Tahir. Excellent talk.